I am Tracy Batchelor from the Massachusetts General Hospital. My topic is primary brain tumors. These are my disclosures. This is an outline of the talk. I will be covering 4 primary brain tumors: glioblastoma, anaplastic oligodendroglioma, low-grade glioma, and primary CNS lymphoma. We'll start with glioblastoma. This slide depicts a gross specimen demonstrating a glioblastoma in the cerebral hemisphere, hemorrhagic, necrotic. Below this gross specimen are 4 micrographs of features that are essential to make the diagnosis, pathological diagnosis of glioblastoma. One is cellular and nuclear pleomorphism in this panel, mitotic activity, this panel, microvascular proliferation in this panel, and finally necrosis. In this case, a characteristic known as pseudopalisading necrosis, where there is a necrotic core and cells lining up around this necrotic core. These features are required by the pathologist to make a diagnosis of glioblastoma. In addition to histopathological features, we now know that glioblastoma consists of a number of molecular subtypes. The Cancer Genome Atlas was an effort to dissect the molecular underpinnings of glioblastoma. And basically, glioblastoma is divided into 4 molecular subtypes: classical, mesenchymal, neural, and proneural, based on the underlying genetic alterations within the tumor. These are basically used for research purposes at this point. They have not entered clinical practice, but this could change in the future. Glioblastoma is the most common subtype of the larger family of tumors known as gliomas. It is estimated that there are approximately 12,000 new cases of glioblastoma each year in the United States. It's the first or second leading cause of cancer death among young adult males in the United States. The median age at diagnosis is 64, and even in the modern era, the median survival, looking at population-based data, is about 1 year or less. And you can see that 5-year survival is even more dismal. All subjects, 3%, and older patients, less than 1%, have survival at 5 years. So there's a lot of work to do in glioblastoma. We also know that there are important prognostic factors in glioblastoma. Older age is a poor prognostic factor. Conversely, if you're younger than 55, you have a better prognosis. A good performance status in terms of activities of daily living, etc., leads to a better prognosis. The status of a gene, the 0,6-methylguanine DNA methyltransferase, or MGMT gene, is also a prognostic factor. The methylated form of MGMT is the inactive form, and this leads to a better prognosis because MGMT is a mediator of resistance to chemotherapy. So inactivated or methylated MGMT is associated with a better prognosis. We also know that another gene, isocitrate dehydrogenase 1, is associated with prognosis. Mutation in this gene, for reasons that are not altogether clear, leads also to a better prognosis. And some of these features, MGMT and IDH1, are making it into the clinic, and we are using these to discuss prognosis with patients, and some of these factors like MGMT and IDH1 determine eligibility for certain clinical trials. MRI is the gold standard for making the diagnosis of glioblastoma. Most of these are contrast-enhancing lesions, heterogeneous patterns of enhancement, infiltrating borders, as you can see here in this right frontal glioblastoma. There's mass effect in this case with compression of the ventricular system. 99% of these lesions enhance. 90% of the time it's a single lesion on MRI. This is an example of how rapidly these tumors can grow. This was a patient who presented with a seizure and was found to have this small abnormality, and about 2 months later, this abnormality had quadrupled in size, and you can see now there's a heterogeneous pattern of enhancement, edema around it. This was a glioblastoma. We do not have validated guidelines for imaging of glioblastomas. The NCCN has provided some guidance, but this is really consensus-based guidelines. So the guideline is to image with an MRI 2 to 6 weeks after completion of irradiation, then every 2 to 4 months for the first 2 to 3 years of follow-up, and then quote-unquote less frequently. In the modern era of chemotherapy and radiation for glioblastoma, we are noticing more of what you see on this panel. This is a patient with a glioblastoma who had had a resection. There was a large tumor here that was removed. The patient then goes on to receive 6 weeks of standard radiation and chemotherapy. And this is the first MRI after the radiation. And you can see that there's more enhancement, necrotic-looking material here. This is the PET scan, which is hypometabolic over this region. Not clear what was going on here, so this patient had a biopsy, and basically the biopsy showed bland areas of necrosis. So this is actually a treatment reaction to radiation and chemotherapy. And this is recognized in up to 40% of patients on the first MRI scan after completion of radiation. And the risk window for this is usually the first 3 months after completion of radiation. So we really do not change therapy if we see this happen within the first 3 months after radiation. Because as you'll see in the next panel, this same patient, if followed over time and just simply treated with standard of care, you can see that this gradually begins to improve and eventually almost completely resolves. Now there's the mass effect has completely resolved in this case. So this was an example of what is known as tumor pseudoprogression. And again, it's seen usually within the first 3 months after the completion of radiation, and it does not really influence our treatment when we see it. So let's talk about treatment in the newly diagnosed glioblastoma setting. Basically, the 3 arms of therapy are surgery, radiation, and chemotherapy. I will not cover radiation in any detail. This is a standard part of treatment. It's been this way for a few decades now. The patients after their surgery typically receive fractionated daily radiation for about 6 weeks. But I will talk about surgery and chemotherapy for newly diagnosed glioblastoma. And let's start with surgery. So what is the rationale for a craniotomy and an extensive resection? Well, first of all, it provides an adequate amount of tissue for our pathology colleagues to make an accurate diagnosis. And in the era of molecular profiling, like MGMT, IDH1, it also provides tissue for molecular studies. Often, the surgery will palliate mass effect, and symptoms of increased intracranial pressure will often improve. This will allow us to reduce corticosteroids, and it may actually allow for patients to better tolerate their radiation. And often patients will actually exhibit improvement in their neurological symptoms and signs after a debulking surgical procedure. What has not been entirely clear is whether an aggressive resection of glioblastoma would improve survival. There are a number of retrospective studies that suggest this, but until the last few years, we've not had a prospective study to examine this important question. But we do have prospective data now that emerged really after this study. Aminolevulinic acid is a non-fluorescent prodrug. It's taken up by dividing cells like glioma cells, and it's converted into a fluorescent porphyrin. So with a special lens mounted to the operating microscope, the cells that take up ALA turn pink to purple and are more easily differentiated from the surrounding normal brain. The idea here is that ALA will enable the surgeon to do a safer and more extensive resection of a glioblastoma or other kinds of brain tumors. It's extremely safe, and it was studied in several small studies, which led to the launching of this large randomized multi-center phase 3 trial of ALA in newly diagnosed malignant glioma patients who were deemed to be resection candidates by their MRI. And this study was done in Europe. 270 patients were enrolled in the first start at the start of the study. The study was closed at interim analysis because the patients who received ALA had a higher frequency of gross total resection, 65% in the ALA group versus 40% in the non-ALA group, and this was statistically significant. So based on a predefined stopping rule, the study was terminated at that point, clearly showing an advantage of ALA, leading to a higher frequency of gross total resections. The other interesting thing is that of these 270 malignant glioma patients, 243 were glioblastoma patients, and in those patients who had a gross total resection, they had an improved survival versus those who just had a subtotal resection, and that was about 17 months versus about 12 months, and again, this was statistically significant. So this does provide some prospective evidence that gross total resection leads to improved survival in patients with newly diagnosed glioblastoma. I want to talk about chemotherapy now, again in the newly diagnosed glioblastoma setting. Temozolomide is an oral alkylating agent that was shown to be safe, well tolerated in brain tumor patients, and really was studied in this study, a randomized phase 3 study mainly done in Europe and Canada, in which newly diagnosed glioblastoma patients, after their surgery, were randomized to receive radiation therapy alone for 6 weeks, which is the control arm, versus radiation plus daily temozolomide for the entire 6-week period of radiation, and then 5 days of temozolomide each month for 6 months. Over 500 patients were enrolled in this study. The primary endpoint was overall survival, and you can see that the patients who received the combination of radiation and temozolomide had a median survival of 15 months versus 12 months in those who received radiation alone. This was statistically significant. These patients were subsequently followed for 2-year, 3-year, 4-year, 5-year survival. And again, if you look at the chemoradiation arm versus the radiation alone arm, you can see that more patients who received chemotherapy were alive at 2 years, 3 years, 4 years, and 5 years. So this led to the approval of temozolomide by the Food and Drug Administration, and it was rapidly adopted into the standard of care for glioblastoma. So now patients after their biopsy or their surgery routinely receive temozolomide plus radiation for 6 weeks, followed by 6 to 12 months of temozolomide after radiation. Glioblastoma is a highly vascular tumor. I showed you earlier a histopathological specimen showing microvascular proliferation, a pathological requirement to make this diagnosis. This microvascular proliferation, as you can see here in this scan, is largely driven by hypoxia. Hypoxia leading to increased HIF-1 alpha, increased vascular endothelial growth factor expression, leading to endothelial cell proliferation, survival, migration, and the formation of one of these abnormal vascular networks which feed the tumor. It's also known that the levels of vascular endothelial growth factor or its receptor correlate with grade of glioma. The higher the levels, the higher the grade of glioma. So on the surface, it would appear that targeting VEGF and angiogenesis would be an attractive therapeutic strategy. And indeed, I'm going to show you some data subsequently that led to the approval of a humanized monoclonal antibody against VEGF, bevacizumab, as monotherapy for recurrent glioblastoma. But I want to stay with the newly diagnosed glioblastoma setting for now, and there are 2 important randomized clinical trials published within the last year looking at the potential benefit of bevacizumab when it was used after surgery. So in this study, newly diagnosed glioblastoma patients have surgery, and then they go on to receive, they're randomized to receive bevacizumab plus the standard of care, temozolomide radiation, or an intravenous placebo and plus the standard of care. There were 2 trials, AVAGlio, which was industry-sponsored, mainly conducted in Europe, and RTOG 0825, which was sponsored by the National Cancer Institute and was mainly conducted in the U.S. Both studies showed the same thing. If you look at progression-free survival, the time until the tumor starts to grow again, the patients receiving bevacizumab had an advantage. They had extended progression-free survival. However, if you look at overall survival, you can see that the curves overlap, and there was no advantage of adding the bevacizumab to the placebo. Basically, that was the RTOG study. The AVAGlio study showed the same thing. No improvement in overall survival, but prolongation of progression-free survival. One of the issues in these studies is that many of the patients at the time of disease progression went on to receive bevacizumab. In fact, in the RTOG study, crossover was mandated. So if you were on the placebo arm and you had disease progression, you received bevacizumab at that time. So essentially, all patients, nearly all the patients in RTOG received bevacizumab at some point. And this, although crossover was not mandated in AVAGlio, 75% of the patients in that trial also received bevacizumab at the time of disease progression. So the question is, could this crossover have confounded our ability to detect an advantage in overall survival? Because remember, again, both showed an advantage for progression-free survival, but neither showed an advantage of overall survival. So this was an interesting sub-study presented within the last 6 months, the Society for Neuro-Oncology meeting, which looked at the 25% of patients in the AVAGlio study who did not cross over to bevacizumab. So 100 of these were in the placebo arm, and 100 were in the bevacizumab arm. So these patients had bevacizumab terminated at the time of disease progression and received no more drug. So if you look at overall survival in this group of 225 patients, you can see that those who received bevacizumab up front and no subsequent bevacizumab had a seemingly better outcome in terms of overall survival, about a 50% increase. Of course, this is a subset analysis, and we're not statistically powered to do this, but it does suggest that crossover may have obscured an overall survival benefit in these 2 pivotal trials. Okay, that's the newly diagnosed glioblastoma situation. We're now going to turn our attention to recurrent glioblastoma. And at this point, we put all the options back on the table: surgery, radiation, medical treatments. Surgery could be a repeat resection. There's also a polymer that is consists of BCNU, which is an alkylating chemotherapy drug. The surgeon can place this polymer at the time of the resection. It results in a modest improvement in overall survival. It is available. Radiation options would be reirradiation, another course of fractionated radiation, but very few patients are candidates for this, and whether this is really beneficial is not established. And then radiosurgery has also been touted as a potential treatment for recurrent glioblastoma, but there are no randomized trials which show that this provides any advantage. Medical or chemotherapies, I talked about bevacizumab. I'm going to show you the data that led to the approval in recurrent glioblastoma. There are other chemotherapy drugs that are available. This is CCNU or lomustine, and these have a modest improvement in progression-free survival. This is the setting when most patients would be considered for clinical trials. So let's talk a bit about bevacizumab again, but this time is in the recurrent glioblastoma setting. This is one of the early studies of bevacizumab for recurrent glioblastoma. Single institution, phase 2 study. 35 patients with recurrent glioblastoma received bevacizumab, in this case in combination with irinotecan, which is an intravenous topoisomerase inhibitor. By itself is minimally active in glioblastoma. In these 35 patients, and again, these are patients who failed surgery, radiation, temozolomide, over half, 20 out of 35, had radiographic responses like you see here. You can see this large tumor. This is an axial coronal view of the same patient. And you can see after treatment, the tumor, contrast-enhancing tumor, is much smaller. So over half the patients enrolled in this trial had radiographic responses like this. And almost half had no disease progression after 6 months on therapy. This is the so-called PFS6 or APF6, which is a metric that we do look at in recurrent glioblastoma. Typically, with standard chemotherapy, you'd see a 20%, maybe a 25% PFS6, but here this was an impressive almost 50%, having no disease progression at 6 months. So these were very promising data, which led to a randomized, non-comparative phase 2 study, again in recurrent glioblastoma. In this study, all of the MRI scans were subsequently reviewed by a central radiologist. The primary endpoint was this PFS6, and 167 patients were randomized. Randomized again to bevacizumab alone or bevacizumab plus irinotecan. You can see that even after central review, there's an impressive number of patients, 30 to 40%, who have radiographic responses, and the progression-free survival at 6 months held up is between 40 and 50%. So based on this study and one other study conducted at the National Cancer Institute, the Food and Drug Administration approved bevacizumab as monotherapy for recurrent glioblastoma in 2009, and that approval is still in place. There are other randomized studies in recurrent glioblastoma looking at bevacizumab. This was a randomized phase 2 study published within the last year called BELOB. It was conducted in Europe. Again, recurrent glioblastoma patients. They failed their radiation, temozolomide radiation surgery, and they were enrolled in this trial. And basically, there were 3 types of treatment in this trial. There was a combination where bevacizumab was combined with CCNU or lomustine, that's an oral chemotherapeutic, versus CCNU alone versus bevacizumab alone. And if you look at the combination arms, the bevacizumab plus CCNU, there were 2 doses of CCNU, you can see that 60 to 90% of patients were still alive at 9 months versus about 40% in the 2 monotherapy arms. And this was promising enough to convert this study into a randomized phase 3 trial. So now this is a study of recurrent glioblastoma simply comparing bevacizumab plus CCNU versus CCNU alone. They will have enrolled over 300 patients, and we should have a readout on this study within the next year. And this might be potentially our last chance to demonstrate a survival benefit for bevacizumab in the recurrent glioblastoma setting. There's been a lot of interest in immunotherapy, especially with new drugs, agents approved for melanoma, lung cancer, etc. One of the more interesting approaches in glioblastoma exploits the fact that about 40% of glioblastoma patients will have amplification, multiple copies of the epidermal growth factor receptor gene, EGFR. And about 20% of patients with glioblastoma will have a mutation in this gene, the so-called EGFR-V3 mutation. So this is a single institution study looking at a peptide vaccine against the EGFR-V3 peptide. The idea being you enroll the patients who have this mutation, you vaccinate with this vaccine, and the patient can mount an immune reaction against these EGFR-V3 expressing cells. So this study showed that this is a non-randomized study, but patients with glioblastoma who received the vaccine had an improved progression-free survival over matched controls from the same institution, matched for age and other important prognostic factors, but again, non-randomized. but there was a suggestion of improvement in progression-free survival, and there was a suggestion improvement in overall survival for those patients who received the vaccine. So based on these data, a randomized phase 3 trial was launched. This was launched in the newly diagnosed setting, patients with EGFR V3 expressing glioblastoma. Again, that's going to be about 20% of all glioblastoma patients. They are enrolled, they're randomized to receive vaccine plus standard of care, which is radiation and temozolomide, versus just standard of care, which is radiation temozolomide plus a placebo. So this study has now reached accrual, and we are expecting a readout on this randomized phase 3 trial this year. So this is a study that could potentially change the standard of care in a subset of glioblastoma patients who have expression of this EGFR V3 peptide. Stay tuned. Okay, that's glioblastoma. Again, that's the most common primary malignant brain tumor. But I do want to say a few words about two other types of gliomas. One is anaplastic oligodendroglioma. These are contrast-enhancing tumors. About 7% of all gliomas are anaplastic oligodendrogliomas. They have a characteristic histopathological appearance under the microscope, the so-called fried egg appearance. This is actually an artifact, but you can see that there's a clear halo around the nuclei, giving this a fried egg appearance. And about 70% of these patients will have lost chromosomes 1p and 19q, so-called co-deletion of chromosomes 1p and 19q, which is detectable by FISH analysis. Importantly, variable clinical outcomes have been observed in patients with oligodendroglial tumors. There are some of these patients who seemingly do very, very well and live for many years, and there are other patients who seem to do very poorly and have survival of less than 3 years. And the question is, what is driving that? Radiation has been the standard of care for newly diagnosed anaplastic oligodendroglioma, but it was recognized in the late 80s, early 90s that about 40 to 80% of these tumors do respond to chemotherapy, and by that I mean shrinkage of the tumor by at least 50%. And the chemotherapy that was used was PCV, procarbazine, CCNU, vincristine. And importantly, it was also recognized that loss of chromosome 1p or loss of chromosome 1p and 19q, so-called co-deletion, seems to predict chemosensitivity. So 90 to 100% of patients with this tumor that have lost 1p will respond to chemotherapy. So it begs the question, would adding adjuvant chemotherapy, in this case PCV, improve survival? So these trials were launched before temozolomide was available, and that's why this regimen, this older regimen, was used. And there were 2 randomized trials. One was in Europe, EORTC 26951. In this trial, patients were randomized to receive radiation alone versus radiation followed by PCV. The other trial was RTOG 9402, slightly different design but similar concept. So patients randomized again to radiation alone versus PCV up front followed by radiation. And when these trials were reported, and here are the references, in 2006, they both showed the same thing. There was an improvement in progression-free survival in those patients who received chemotherapy, but there was no difference in overall survival. So chemotherapy did not appear to extend overall survival in these patients. However, with long-term follow-up, a striking difference in overall survival emerged. And this was specifically in this subset of 1p19q co-deleted patients. And again, this is about 70% of all anaplastic oligodendrogliomas. And what was observed with long-term follow-up is that the patients who had received the chemotherapy in addition to the radiation had approximately double the survival. 14.7 years in the chemoradiation arm versus 7 years in the radiation arm. And importantly, this was seen in both studies with long-term follow-up. So this highlights the importance of chemotherapy in this subset of anaplastic oligodendroglioma patients who have 1p and 19q co-deletion, and it highlights the importance of testing for 1p and 19q, so appropriate therapy can be implemented. So chemotherapy has now been established as part of the treatment program for this subset of patients. What is now debated is whether we should use the older, more toxic PCV regimen, because after all, that's what demonstrated these results, or whether temozolomide might be as effective as PCV. Temozolomide is certainly better tolerated than PCV, but again, we don't have the actual data with temozolomide in the mix. That is an ongoing debate. Let me say a word about low-grade gliomas. These are mainly seen in younger patients with brain tumors. I want to highlight one important randomized trial, the final results of which were presented within the last year. Basically, the idea here is that patients with low-grade, grade 2 gliomas have surgery and then are randomized to receive radiation alone, standard fractionated dose of radiation, versus radiation and PCV. And again, this trial was launched in the late 90s before temozolomide was available. The other important thing to recognize about this study is that this study only enrolled so-called high-risk low-grade gliomas, because patients who are not high-risk with low-grade gliomas, while management is controversial, can even be observed. But those with high-risk low-grade glioma have an increased likelihood of their tumor recurring. And so how do you define high risk? Well, in this study, they defined high risk as anyone over the age of 40 or younger patients under the age of 40 who had an incomplete resection. That was the definition of high risk. So applying this definition, they enrolled 251 patients. They were randomized to these two arms, radiation and PCV versus radiation alone. And the median follow-up now is at 12 years. Now, I will point out that when this was originally published, we saw similar results as the anaplastic oligodendroglioma story. That is to say that there appeared to be some benefit to progression-free survival, but there was no apparent benefit of chemotherapy for overall survival. But with longer follow-up, again, a survival advantage has emerged for those patients who received PCV. You can see that a 14-year median survival versus an 8-year median survival for patients who just received radiation. This is statistically significant. Again, highlighting the importance of following patients that enroll in these studies long enough so that we can make some assessment of overall survival. Now, this study also has engendered a lot of discussion because now we know that low-grade glioma is several different biological subtypes of glioma. Importantly, the IDH1 mutation plays a key role in prognosis. And so it will be important for this study group to look back at the tissue if possible to see which molecular subtype appears to be benefiting most from the addition of chemotherapy. But very exciting, provocative results. Again, establishing a role for chemotherapy even in low-grade gliomas at high risk. The last tumor I want to talk about this morning is primary CNS lymphoma. So we're leaving the glioma family of tumors, and we're going to talk a bit about this tumor. This is a rare extranodal form of non-Hodgkin lymphoma confined to the CNS, brain, spinal fluid, and we include the eye with this type of tumor. Rare tumor, approximately 1,300 new cases each year in the United States. Median age at diagnosis is 65. In terms of the pathology, 90% of primary CNS lymphomas are of the diffuse large B-cell subtype. And importantly, if you further subdivide diffuse large B-cell lymphoma by gene expression patterns, more than 90% of primary CNS lymphomas have the activated B-cell type, or the ABC type. This is much higher than what you see when diffuse large B-cell lymphoma occurs elsewhere in the body, that is, outside of the brain. This is a H&E slide from a patient after a needle biopsy. Most of these diagnoses are made by biopsy. And you can see a cerebral blood vessel in the center, and clustered around this blood vessel are all of these malignant lymphocytes. If you look at diffuse large B-cell by organ type, you can see that the diffuse large B-cell, when it occurs in the brain, has the worst prognosis of any other organ type. And the reason for that is not altogether clear, but some of this certainly may be driven by the fact that more than 90% of the CNS lymphomas are the ABC type, which has an inferior prognosis compared to other gene expression profile patterns in lymphoma. This is a CT scan, an MRI scan, and a PET scan showing some of the characteristic radiographic features of primary CNS lymphoma. Here on the CT, you can see homogeneous enhancement of this lesion in the splenium of the corpus callosum. This is the same patient a few hours later who had an MRI. You can see that the MRI shows the callosal lesion, but the increased sensitivity in the MRI picks up enhancing disease also outside of the corpus callosum. These are usually hypermetabolic on FDG PET scans of the brain. As you can see, this is a different patient, but you can see a lesion near the caudate nucleus that is very bright on FDG PET. The most common set of symptoms patients present with are mental status alterations. These are usually subacute in their presentation over weeks to a few months. We know that age and performance status are very important prognostic factors. You can see that you can divide primary CNS lymphoma into 3 different prognostic groups just by using age and performance status. So the younger age, better performance status are the patients who have the better outcomes. This is a multi-compartmental disease. It can involve, again, the eye, the brain, the CSF. The data I will show you here is from a study of over 400 cases of primary CNS lymphoma. These were all in immunocompetent hosts. And in this series, about 1/3 had multiple lesions, 2/3 had a single lesion. If you look at distribution of the lesions in the brain, basically parallel blood flow with most of the lesions in the frontal lobe. The so-called classic location of CNS lymphoma is deep periventricular, but only about 40% of patients in this series had deep lesions. When they looked at involvement of the eye, and again, about 13% of patients had concurrent involvement of the brain as well as the eye, highlighting the importance of a thorough ophthalmological evaluation by an experienced ophthalmologist when this diagnosis is made, because this may influence how patients are treated. In this same series, 16% had involvement of their CSF or leptomeninges, highlighting the importance of lumbar puncture and CSF assessment. The International Primary CNS Lymphoma Collaborative Group, or the IPCG, has established baseline evaluation criteria for this disease, highlighted here. So patients should have, of course, brain imaging. The gold standard is contrast-enhanced brain MRI. When safe, a lumbar puncture should be performed for cytology, flow cytometry, and PCR for IGH gene rearrangements. As I mentioned, an ophthalmologist should evaluate the patient, and they should include a slit lamp evaluation as part of their assessment. And then in order to prove that this is primary CNS lymphoma, body imaging with CT PET is advised, as well as bone marrow biopsy. Because this is a multi-compartmental disease, it is important in assessment of response to take account of each of these compartments. So the IPCG has also published response criteria that have been incorporated into clinical trials. These include brain imaging, eye examination results, and CSF results. And we can define complete, partial responses, etc., based on various combinations. And I will refer you to this reference for details. And like I said, these are the criteria that have been incorporated into clinical trials. I want to tell you now about 3 randomized trials which are establishing the standard of care in primary CNS lymphoma. Because this is a rare disease, there are very few randomized trials, but I want to tell you about 3 of them. This was a randomized trial in patients who were newly diagnosed with primary CNS lymphoma. And the question that was being asked here is, what is the optimal chemotherapy for these patients? So chemotherapy has largely been centered around methotrexate. And in this trial, patients were randomized to receive methotrexate alone or methotrexate plus another chemotherapeutic, Ara-C or cytarabine. So combination treatment versus methotrexate alone. And in this trial, after chemotherapy, all patients went on to receive whole brain radiation. So here are the results. So in the patients who received methotrexate alone, 18% achieved a complete remission versus almost 50% who were treated with methotrexate and cytarabine. And this is remission only after chemotherapy. So adding the cytarabine to methotrexate does clearly improve complete remission rates. Now, again, all patients went on to receive whole brain radiation after their chemotherapy. And these are the progression-free, or in this case, failure-free survival curves and overall survival curves. And importantly, it shows that this benefit of combination methotrexate and cytarabine it also extends to failure-free survival. So these are the 2 drugs versus the 1 drug, and overall survival. Patients who received the combination had better overall survival. So this has led many to argue that methotrexate and cytarabine should be the standard chemotherapy induction in patients with primary CNS lymphoma. And certainly this has been incorporated as a control arm in some of the other ongoing randomized trials. One of the problems with treating primary CNS lymphoma is that our treatments, and especially the whole brain radiation, is associated with neurotoxicity. And this is especially important for patients over the age of 60, where virtually all patients will have some degree of neurotoxicity after whole brain radiation. And these are patients who can live for many years, so they live long enough to experience this toxicity. So this has led many in the field to advocate for either reducing the dose of whole brain radiation or eliminating whole brain radiation altogether. And this was a trial that asked this very question, whether we can eliminate whole brain radiation therapy. So this was a randomized trial done in Germany. Over 500 patients were enrolled. The basic idea here was patients were treated with chemotherapy alone involving methotrexate or chemotherapy and whole brain radiation. So a chemoradiation arm versus a chemotherapy arm. And in this analysis, if you look at the intent to treat analysis, there was an advantage of adding the whole brain radiation to progression-free survival. So patients had some extension of their time before disease progression if they received the whole brain radiation. However, if you look at overall survival in this intent to treat analysis, there was no difference in the two study groups. So deferral or elimination of whole brain radiation in this trial did not compromise overall survival. And so there are many strategies now that are looking at different chemotherapeutic approaches in lieu of or instead of whole brain radiation. There are also some approaches that are combining chemotherapy with lower doses of whole brain radiation with the idea that potentially we can mitigate neurotoxicity by lowering the dose of whole brain radiation. But this was an important study in terms of demonstrating that there was no compromise in overall survival if whole brain radiation is deferred. This is another randomized trial looking at a particular subgroup of patients with newly diagnosed primary CNS lymphomas. These are so-called elderly patients. So in this trial, you were defined as elderly if you were over the age of 60. And this is important because the median age at diagnosis of this tumor is over the age of 60. So this approach applies to more than half of all patients with primary CNS lymphoma. So this was a randomized phase 2 trial. Patients over the age of 60. The primary endpoint was progression-free survival. About 100 patients were enrolled. And in this trial, there was no whole brain radiation. And the reason for that is that this group over the age of 60 is at especially heightened risk of neurotoxicity with radiation. So there was no radiation in this trial. It was all chemotherapy. The two arms, half the patients were randomized to so-called MPVA, and again, both of these are built around methotrexate. MPVA is methotrexate, procarbazine, vincristine, and Ara-C, versus a more simplified regimen, methotrexate and temozolomide. You've heard about temozolomide. The results, median age of patients enrolled, 72. Progression-free survival, the primary endpoint, for the MPVA, the more aggressive but potentially more toxic chemotherapy, 9.5 months PFS. The PFS for methotrexate and temozolomide, 6 months, but this was not statistically significant. And there were also no statistically significant differences in radiographic response and overall survival. So this did not demonstrate that a more aggressive chemotherapy regimen is any better than using a simplified version of methotrexate and temozolomide. It's a very exciting time in primary CNS lymphoma. I've told you now about 3 completed randomized trials. There are multiple other ongoing randomized trials in primary CNS lymphoma asking questions about the ideal kind of chemotherapy to use in the induction period of treatment, and asking questions, what is the ideal type of consolidation treatment that comes after patients are in remission. Looking at, a lot of these looking at high-dose chemotherapy and stem cell transplants, which have shown a lot of promise in phase 2 trials. So, to summarize, just to walk through each of these tumors again, glioblastoma, the most common primary malignant brain tumor. We are now using molecular markers of prognosis that are available commercially and at various institutions, MGMT and IDH1. Resection, if feasible, followed by chemoradiation is the standard of care. Bevacizumab alone or chemotherapy alone is the standard of care at recurrence. We are awaiting the results of 2 randomized trials that I told you about, BELOB and the vaccine trial, which should be out this year and might change the standard of care again for glioblastoma. In terms of anaplastic oligodendroglioma, it is very clear that the addition of chemotherapy to surgery and radiation extends survival in the 1p19q co-deleted subset, which is the majority of these tumors. In terms of low-grade glioma, new data suggests that the addition of chemotherapy to surgery and radiation extends survival in the so-called high-risk group of patients with low-grade gliomas. Primary CNS lymphoma is an uncommon subtype of non-Hodgkin lymphoma. Methotrexate-based chemotherapy is the standard induction, and it appears that combination chemotherapy is important. We do not know yet what the optimal consolidation treatment after a patient has achieved a remission should be. And various strategies being looked at in this setting include high-dose chemotherapy and stem cell transplant, reduced dose whole brain radiation, or other types of chemotherapy. Thank you very much.